investigation. For diagnosing anything, we don't require to go on doing plenty of investigations, plenty of blood tests and all. Fibroid is a beautiful thing which we can feel with our hands. God has given us to do the pelvic examination and all. Even if it is not picked by that, the most easiest investigation to pick the fibroid is, or the investigation of choice is, ultrasonography. By ultrasonography, we can pick plenty of the fibroids. Now let's come to the management. How do we treat the fibroid? Now I have a patient of 40 years old who has come to me for a regular checkup with a scan showing there is a 4 centimeters fibroid. I am telling the patient, what are your complaints? She is like, see the scan, there's a fibroid. See a scan, there's a fibroid. Now what do you expect for the management of such patients? What did I tell you? The most fibroids are asymptomatic. If you do a scan, and nowadays if you do a scan, if in 100 people, almost 40% of them can have a fibroid. But as they are asymptomatic, all asymptomatic fibroids need not to be treated. When they are not causing any problem to us, you should not touch them. That's the simple thing. So management mainly depends on the symptomatology, whether they are symptomatic or asymptomatic. Asymptomatic, no need to treat. So they can give you a clinical scenario also, where they will tell a patient 45-year-old has come with a fibroid of 4 centimeters, presenting no symptoms, what will be the management? You have to write just regular follow-up for that. You have to choose a regular follow-up for her. But there are some conditions where even asymptomatic fibroids we need to treat. So what are the indications of asymptomatic fibroids needing treatment? Pedunculated fibroids. Pedunculated subserosal fibroids need to be treated as they are prone for torsion. Okay, so pedunculated subserosal fibroids need to be treated. Then unexplained infertility. They don't have anything else apart from this fibroid and they're not getting pregnant. So maybe this might be the cause. That time we might have to remove it. And any fibroid which is causing pressure symptoms, like there's a broad ligament fibroid which is pressing on the ureter and causing hydronephrosis. Any pressure symptoms also, we have to remove that fibroid. Okay. Earlier days there was a concept that when a fibroid is more than 12 to 14 weeks you have to remove, but nowadays they tell even if it is a size of 12 weeks or 14 weeks, it is not causing any pressure symptoms or not causing any problem, no need to remove. So asymptomatic fibroids you have to remove or you have to treat only when they are pedunculated subserosal fibroid, when there is unexplained infertility, when there are pressure symptoms, and when your diagnosis is not certain. So this is regarding the management of asymptomatic patients. Now patients who come to us with symptoms, what can we do for them? So symptomatic patients, we can either treat them with medical management or surgical management. We have medical management or surgical management. In medical management, what we have is, you have non-hormonal. So what are the indications of medical management? When all we do medical management? So in the management for the symptomatic patients, we have medical management and surgical management. Coming to the medical management, all the medical management are just temporary measures. They are only for the temporary, okay? And for whom we give these temporary measures? Patient who is not fit for surgery. where we want to reduce the size of the fibroid so that we can remove laparoscopically or through the vaginal route. Or patient who is approaching menopause, as I told you, it is estrogen dependent. So in menopause, estrogen comes down. So fibroid will regress in size automatically. So those patients you don't want to do any surgery, and patients who want to treat your anemia. So these are the medical management conservative steps which we can indications. Okay. Now coming to the medical management, we have non-hormonal drugs and hormonal drugs. So non-hormonal drugs, mainly these are for reducing the symptoms of bleeding as well as size of the fibroid. But mostly they reduce the bleeding of the fibroid. Mainly we have tranexamic acid and NSAIDs. NSAIDs mainly mefenamic acid. They reduce the dysmenorrhea and to some amount even the bleeding also. Okay. In hormonal, now coming to these drugs, most of the estrogen dependent, wherever the estrogen is the cause in gynecology, like estrogen is the one culprit for fibroids, estrogen is the culprit for adenomyosis, estrogen is the culprit for endometriosis. Everywhere where estrogen is the crucial thing which is causing the disease, these are the same drugs which we use. As a gynecologist, we don't have plenty of drugs to play with. These are only certain drugs which I'll be dealing in some next session, where all these drugs I'll be elaborately telling. But here, to deal with all these drugs, mainly help in the reduction of the bleeding as well as size of the fibroid. Now coming to the recent advances in the medical management, we have got a new drug which is ruling now, is selective progesterone receptor modulator. So we have SPRM, selective progesterone receptor modulator. Mainly it is called ulipristal acetate. This can come as an MCQ because this is the recent advances and we have started using in India also. So ulipristal acetate is a selective progesterone receptor modulator which comes in a dose for a fibroid as 5 mg or 10 mg. Trials have, and you know all that it is evidence-based medicine which we are practicing. So trials are over and it is released in the market. This has shown to, does it act? It acts by causing anti-mitotic effect or anti-proliferative effect on the myometrium. And it has reduced the size of fibroid and it decreased the bleeding also. We give this tablet either 5 mg or 10 mg for 3 months. We can give only for 3 months and it has shown to decrease the size as well as bleeding. And one more thing which you should know about ulipristal acetate is, actually it does not come for the fibroid, it was actually for emergency contraception. So it was actually for emergency contraception. The dose for emergency contraception is 30 milligrams, should be taken within 120 hours. It should be taken within 120 hours and its efficacy has been proved better than levonorgestrel. Okay, and the trade name which it comes as ELA. This is regarding one of the recent advances, that is the SPRM or ulipristal acetate. One more drug is there which is in trial, asopresinol. If it comes, you can, drugs which can be used in fibroid, we can write this also. This is also an answer, asopresinol. Okay. Now coming to the surgical management. So in surgical management, one thing, you remove the entire uterus with fibroid, that is hysterectomy. No headache. But different routes, you can either remove through vagina, you can remove abdomen, you can remove laparoscopy, you can do robotic, anything. But another is where you want to preserve the uterus. So whom you want to preserve the uterus? That is a nulliparous patient who has come with a big fibroid, who want to conceive. So for them what we do is myomectomy. So again, myomectomy can be done laparoscopically, hysteroscopically, or abdominally. Indication for myomectomy is patient with unexplained infertility and who want to preserve the uterus. Now, there is something recent advances in the surgical management also, which we are going to discuss today now. We have got uterine artery embolization, radio ablation therapy, and the last one is HIFU, high frequency ultrasound ablation. It's also called MR HIFU. That is magnetic. Actually, about the fibroid, it is the most common solid benign pelvic tumor. And it is etiology 50% are because of the chromosomal translocations, and it is estrogen and progesterone dependent. Types, we have uterine fibroid, extrauterine fibroid. In uterine fibroid, we have intramural fibroid, submucosal fibroid, and subserosal fibroid. Among these three, which is the most common, 75% of them are intramural fibroids. And we have extrauterine or cervical and broad ligament. Clinical features, more than 50% are asymptomatic. And the MCQ which you have to remember here is, most common fibroid which causes maximum symptoms are submucosal fibroids.
Next.
And the investigation of choice which we do is USG. Treatment mainly depends on the whether patient is symptomatic or asymptomatic. Symptomatic, we can have medical measures or surgical measures. Asymptomatic, no need to treat.